This is the beginning of Test 2 material. This is the first part of 2 lectures covering obesity surgery and devices. Medical science has yet to come up with a diet, exercise, or drug that's guaranteed to make fat people thin. But there's considered to be one reliable solution, and that is surgery. Now, a couple of procedures we're going to talk about, gastric bypass and gastric banding, can take weight off almost immediately. It's been identified as being able to cure some type 2 diabetes practically overnight, in addition to lowering of blood pressure in some, as well as cholesterol levels. In general, at least 10 million Americans are heavy enough to be eligible for these surgeries. Now, to be eligible for these surgeries, the individual must be at least 100 pounds overweight. For weight loss surgery patients on the whole, the risk for dying during these procedures or shortly after the surgery is low, and it continues to get lower. It's currently on average about a 1% risk for bypass patients and about a 0.5% risk for banding patients. This risk is going to be affected by the doctor's experience, the patient's weight, as well as their health at the time of surgery and the patient's age. Now, both bypass and banding can produce complications for all patients, as well as the other procedures we're going to talk about. Up to 20% of bypass patients had a problem during the surgery or within 30 days following the surgery. And this can range from severe vomiting and reflux to gastric leaks. Gastric banded patients tend to have fewer problems, and it's most likely because this particular procedure leaves the digestive system intact. Now, with these patients, nutrition is another concern. Most of the patients will initially have great difficulty eating meat, and foods that are dry will tend to clump into a ball and feel uncomfortable. To avoid protein deficiency in these patients, then patients are going to have to learn how to eat more digestible protein-rich foods like cottage cheese, scrambled eggs, powdered shakes. So there's definitely going to have to be some changes in lifestyle taken into account to facilitate the success of these procedures. Types of surgery include gastric bypass, sleeve gastrectomy, and biliopancreatic diversion with a duodenal switch. This is also known as a BPD-DS. Gastric bypass. Now, with the gastric bypass, the average procedure cost is from $20,000 and up. With this process, with this procedure, it is a permanent rerouting of the digestive system. And these patients can commonly suffer from a syndrome that's known as dumping syndrome, especially for the first year or so following the bypass surgery. Alright, so here's an illustration of one type of bypass, gastric bypass procedure. This is known as the Roux-en-Y gastric bypass, often abbreviated as the RNY bypass. The left illustration is showing a normal, intact GI tract with the stomach, the duodenum, and the jejunum. The dotted lines up around the superior stomach are showing where the 1 to 2 tablespoon size pouch is created in this process. The dotted line in between the duodenum and the jejunum is showing where an incision is made, and the jejunum is then pulled up to attach to that small pouch that has been created, as the illustration on the right reflects. So with this procedure, we see a 1 to 2 tablespoon pouch created by stapling the stomach. It detours food around the upper 20 to 60 inches of the small intestine. This procedure accounts for approximately 80% of weight loss surgeries in the United States. And it was initially performed with a 10-inch incision that was very risky for obese patients. It's currently being performed with laparoscopy that uses 4 to 5 small incisions. So the idea with this procedure is that with that 1 to 2 tablespoon size pouch, is that the patient is going to feel full after eating tiny portions of food, and then they're going to stop eating. Now, due to bypassing the initial section of the small intestines, where you have a major portion of the nutrient absorption occurring, these patients will no longer completely absorb the vitamins and minerals like normal systems. So it's common for these patients to suffer from what's known as the dumping syndrome for the first year or so following the bypass surgery. In addition to this presentation, it includes nausea, diarrhea, dizziness, and the diarrhea can last for like 12 hours following ingestion of cookies or other high-carb foods. Now, it's important to recognize the idea again behind this is that when the patient feels full after eating a tiny amount of food, they will stop eating. Well, that may be an issue because there are a lot of people that continue to eat past that satiety feeling. When they feel full, it's not like they'll necessarily stop. Eating can be driven by emotions and stress as well. Before these people have this procedure, they typically have to go through counseling, and they typically have to show the ability to lose a certain percentage of weight before they will be allowed to have this procedure performed. Because if the person does not change any of their lifestyle activities that are contributing to what got the obesity state developed in the first place, they're not going to be as successful with this procedure. Now, in the first 2 years post-surgery, bypass patients will lose on average 62% of their excess weight. Well, if you take that a person is 100 pounds overweight, then what that means is that in their first 2 years post-surgery, they should lose approximately 62 pounds or 31 pounds a year. Well, now technically with diet and exercise, a person should be able to lose a half a pound to a pound a year, which would allow them to lose the same amount of weight. The problem is, or one of the problems, is that with their lifestyle, those issues that are in place that contribute to excess calories consumption play a role with this. Also, if they're morbidly obese and they're having problems with low back pain, for example, lower extremity pain, and they can't exercise, that's going to inhibit their ability to lose the weight. So in terms of cost effectiveness, their overall health, their age, all their clinical presentation, it may be more effective to consider this. Now, there is a percentage of patients for which gastric bypass isn't successful, and some of these patients will actually begin to regain their weight back pretty quickly. The next procedure is the sleeve gastrectomy, also known as the vertical sleeve gastrectomy, also known as the vertical gastroplasty. So, with the sleeve gastrectomy, it is designed to restrict food intake and decrease the amount of food that can be used by the body. The majority of the stomach is removed during the procedure, and the remaining stomach is approximately the size of a banana. This is performed with laparoscopy, and it is non-reversible. So here's an illustration of a sleeve gastrectomy. Notice they go in and they do a series of staples or stitches, and then they remove the largest portion of the stomach, leaving a banana-sized portion for the stomach. The excised stomach is fully removed from the body, so it is non-reversible. The other thing with this procedure is that it keeps the duodenum intact and the jejunum, so the contents that do get into the stomach are going to be able to go through the normal GI process, moving through the duodenum and the jejunum. Again, the idea is that with the stomach being smaller, the person's going to feel fuller faster, and they will then stop eating. The final surgical procedure we're going to cover is the biliopancreatic diversion with the duodenal switch, also known as a BPD-DS. Now, the BPD-DS is partially reversible. The small intestinal surgical portion of the procedure is reversible. The stomach portion of the procedure is not, because the stomach portion of the procedure involves the completion of a sleeve gastrectomy. So they're going to remove the majority of the stomach, and it is going to be removed from the body, therefore it is not reversible. The small intestinal portion of the procedure is a rerouting of the food away from the majority of the small intestinal tract. And if the contents are not able to move through the small intestinal tract, then it will be limiting the amount of absorption. The final component is this procedure changes how bile and other digestive juices can affect the body's ability to digest food and absorb the calories, because it limits the amount of exposure to the digestive contents with the digestive enzymes, so it will greatly limit absorption. So here's an illustration of the BPD-DS. So let's take a few moments and work through this illustration. In the upper right-hand corner, you'll notice it says stomach sleeve and lateral stomach removed. So here is where the sleeve gastrectomy is performed. And the lateral stomach is separated and it's removed from the body. And it leaves the stomach sleeve that's still intact with the esophagus and with the proximal duodenum. So then they're going to go down just a few centimeters into the duodenum and they're going to create an incision. They're going to cut through the duodenum. So notice where the duodenum line is pointed on the illustration, just under the liver, and then there's a black dotted line. So they're going to cut there. The green tube that is behind the alimentary limb is the distal duodenum. It is left in place. It still remains intact with the necessary ducts so that the pancreatic enzymes and the bile from the liver can be introduced into the duodenum. It's then going to travel down the length of that greenish tube. Now, at the ileum, they're going to make another incision, and they're going to pull the alimentary limb, which is the distal ileum, up and attach it to the proximal duodenum. Then they're going to take the green tube, which is where the digestive enzymes are moving through, which would be the proximal ileum, and they're going to create basically a fistula, and they're going to attach the end of that tube into the distal ileum. So it allows the digestive enzymes to move through that green tube and be introduced at the very distal end of the ileum, just before the contents will move into the proximal colon. So again, when we're looking at the food movement, the food is going to move through the stomach sleeve and through the proximal duodenum and right into the distal ileum, moving towards the colon, and then the digestive contents are going to move through the green tube that's identified as the BPL, and then at the very end you'll see where it says the location where the digestive juices mix with the food. They come together in a common channel in literally just a few centimeters before the contents enter the colon. Well, that means that it's only at that very distal aspect that there's the opportunity for absorption of nutrients. Now, in addition to obesity surgery, we also have obesity treatment devices, and there's three types we're going to talk about. The first one is gastric banding or gastric bands. This was FDA approved in 2001 and then 2007. Gastric balloon systems that were FDA approved in 2015, and then electrical stimulation systems that were FDA approved in 2015 as well. Gastric banding. So gastric banding or gastric bands are completed via laparoscopy. They consist of a silicone band, tubing, and an access port. So what they will do is through laparoscopy, they will go in and place an inflatable silicone cuff around the stomach. and the cuff is inflated to create a small pouch, typically 1 to 2 tablespoons in size, at the superior aspect of the stomach, with a restricted opening to the rest of the stomach. Now, the idea is the created pouch will fill quickly, it empties slowly, and it's going to create a feeling of fullness, which will again then have the patient stop eating once they feel full. The digestive system remains fully intact with this procedure. Now, one of the challenges with this procedure is that overeating will often cause undigested food to back up into the esophagus. However, a couple of nice things about this procedure is the fact that it keeps the digestive system intact, so it allows all the normal physiological functions to occur as contents move through the GI tract. And if weight loss is too rapid or too slow, the cuff can be loosened or tightened by using a syringe to adjust the amount of saline solution that's in the cuff through a small implanted port that's located under the skin. Now, in the first 2 years post-surgery, banding patients will lose on average 47% of their excess weight. So on average, within 2 years, a person that has 100 pounds to lose will lose 47 pounds. Now, there are some studies that have been performed in Europe that suggest that patients lose more weight in the long run with bypass surgery, but there's also other studies that indicate that the weight loss is about the same between bypass and gastric banding. So I think it really depends upon each individual patient. Here's an illustration of the lap band gastric banding system that was FDA approved in 2001. So you'll notice that on the picture on the left side, it shows the silicone band that's around the superior aspect of the stomach and how it creates a small 1 to 2 tablespoon size pouch. And then you'll notice how it shows the gastric band and the connecting tubing on the right, as well as the access port that's underneath the skin in which saline can be added or removed in order to address the diameter of the actual gastric band and support the rate of emptying from the small pouch into the rest of the stomach. Now, this is an illustration of the realized gastric banding system that was FDA approved in 2007. Gastric balloon systems. Now, these systems are used in adult obese patients with a BMI of 30 to 40, as well as a history of being unable to lose weight with diet and exercise, and these patients must also have one or more obesity-related condition like diabetes mellitus, hypertension, documented hyperlipidemia. Now, these balloon systems are intended to be used while the patient is participating in a diet and exercise plan that is supervised by a healthcare provider. These systems are a temporary system because there is a risk associated with these systems of balloon migration and possible bowel obstruction. Also, it's been found that with these systems, longer implantation time is unlikely to produce greater weight loss because what's been found is that these non-adjustable balloons lose their effect on appetite, within about 3 to 4 months' time. The Orbera intragastric balloon system was FDA approved in 2015 for use. This system uses a gastric balloon that occupies space in the stomach, and it works by taking up space in the stomach to help the patients lose weight. Basically, the idea is if you've got the space taken up in the stomach, a small amount of food will make the patient feel full, and then they will quit eating. Again, this is a temporary system. It's removed after 6 months due to the risk of balloon migration and bowel obstruction. Now, there are several contraindications for using this system, and the list I'm going to provide you is a partial list. So, it's contraindicated to use this system if the patients had prior GI or bariatric surgery, if they have an inflammatory GI tract disease, in the presence of a large hiatal hernia, if they've been diagnosed with a severe or serious esophageal motility disorder. It's contraindicated in the presence of a gastric mass. It's contraindicated for use in the presence of severe clotting or bleeding disorders, as well as liver failure or cirrhosis. It's contraindicated if the patient has had prior or present psychiatric illness. It's contraindicated for use in alcoholism or drug addiction, as well as in pregnant or breastfeeding females. Here's an illustration for your review of the Orbera intragastric balloon system. Now, the Reshape integrated dual balloon system is another system that was FDA approved in 2015, and this system consists of two attached balloons that are filled and sealed separately. The balloons are placed into the stomach using a minimally invasive endoscopic procedure. The patient is put under mild sedation. Once it's in place, the balloons are filled with saline and blue or methylene dye. That way, if a balloon breaks, the blue dye is going to appear in the patient's urine. Now, when it's time for removal, again at 6 months, the balloons are going to first be deflated through endoscopy and then removed. Here's an illustration of the Reshape integrated dual balloon system. Electrical stimulation systems. The Maestro rechargeable system was FDA approved in 2015. This is an intra-abdominal vagal nerve blocking therapy. So an electrical stimulator is implanted via laparoscopy into the abdomen to block nerve activity between the brain and the stomach. So this system is responsible for transmitting intermittent signals to the vagus nerve to affect stomach emptying and the brain's perception of stomach fullness, stomach emptiness. So it's currently known that the device blocks nerve activity between the brain and the stomach. As for specific mechanisms for weight loss due to the use of the device, unknown. Here's an illustration of the Maestro rechargeable system. Please review it.